record. Perfect. All right, Nikki, over to you.
Yeah. Okay, thank you so much, very much, Dr. Van Horne, for jumping in here for us to do this June edition of Menopause Mondays. We are so thrilled, Natalie and I are thrilled this going. So let us just jump straight into it. You want to introduce yourself, a little bit about what you do, where you are, and just give us all the juicy details, please.
Okay, so I am Dr. Simone Van Horne. I am in South Florida. That's where I'm based right now. I have been an internist for more than 20 years. I kind of like to leave it like that. I'm originally from Jamaica. I did my formative years at the University of the West Indies. I did my internship, my first one at KPH, and then I went up to the States and I redid my internship, and I did my residency in internal medicine at Penn, University of Pennsylvania, and have been working ever since in internal medicine. And I've worked in a variety of areas, I guess, which have sparked my interest at different times. After leaving residency, I worked in HIV. I've done the garden variety, internal medicine in the office. I've worked in hospitals. I've worked in ICU. I work in the ER. I did that for a long time, worked in acute care. And I guess I'm at this point where I kind of felt like I was just checking boxes, and not that I wasn't helping people to get healthier, but I wasn't getting to the root of the problem. And for me as a woman, I guess that started to happen like around about when I started going to menopause. And so I started doing the research, and I guess that journey has kind of led me here to this point in my career, where I do internal medicine, but I have a lot of emphasis on the root cause, and practicing on my own affords me that freedom to be able to do that, and not be limited if I'm working for a corporation or for a hospital or for whoever.
Gotcha. So that's very exciting. I love the fact that you're speaking from experience as well, because your journey of menopause, you're speaking firsthand, and that's what I really love about that. And I think that, in all the research that we read and we talk to people, women are just not, they're going to doctors and they're not getting the answers, because I feel that a lot of the doctors, they don't have a clue. They're not going through it. So the fact that you're going through it, you can speak from experience. I love that. So thank you for that. And I love for us to jump straight in. Okay, so before we get into the nitty-gritties of HRT, what are the bigger boys, as I like to call them, the health risks of the falling hormones, our bodies, our organs, all of that? Before we get in the hot flashes and stuff, which we can turn on the fan and we can do all of that stuff. The big boys, as I like to call it, the heart, the liver, the kidneys, everything. What are some of the health risks that come from the falling hormones during and after menopause?
Well, let's preface that by saying that you have hormone receptors all over your body for testosterone and estrogen. So when you start to fall off in terms of your hormones, it is a pan-systemic issue, right? So we have lots of receptors on our brain. We have lots of receptors on our eyes, which is why we have to wear glasses all of a sudden one day. We have hormone receptors on our heart. We have hormone receptors on our vertebral column, in our bone, in the hips, in our bones, in our hands, in our muscles, in our gut. And so when the hormones decline, I think that's what kind of confuses us, and has confused probably the medical fraternity for such a long time, where it's a lot of things that you can call anxiety, or you can call you have reflux, or you can call you have like constipation, or you can call it you just having whole headaches because life is stressful. But really, the whole makeup of all of those symptoms are really menopause and declining hormones coming in. And although this is for women, us talking about HRT, what is becoming increasingly obvious is that also men are going through the same thing, right? They go through it at a later time because they have more testosterone. But us as men, us as women, and they as men, we both have testosterone and estrogen. We have more estrogen and less testosterone, and they have much more testosterone and a little less estrogen. But we both need both of those hormones to be in balance, right? Estrogen is very good at decreasing our cardiovascular disease, which is why women tend to not have issues with heart attacks and strokes, etc., because of that covering of estrogen. And then when we lose that covering, here comes like all of that, right? Men have less estrogen, and so they get heart attacks earlier, right? So there's that, right? Testosterone makes you want to have sex, right? Be interested in sex, want to do new things, want to go out more. And so you kind of find in relationships, women will be like, no, I don't want to go out tonight. I can't bother. And I, I can't. No, you're just not interested. You don't want to have sex. Where men want to have sex for longer because they have more testosterone for longer. And then the same thing happens to them though when that falls off, right? So when I look at somebody hormonally, I can really tell a lot from the symptoms that they're having, just on the face of it, right? So common questions that I ask would be like, are you exhausted? Are you anxious? Are you irritable? This is for men and women. Are you having more joint pains? Is it difficult for you to recover after you exercise? Do you find that you need more sleep? Do you find that your memory is going? Do you find that you're in the middle of a conversation, you can't remember people's names? I mean, all these things we just kind of like laugh off and say, oh, I'm just getting old. But what is about the aging process that's causing that? And if that happens, is there something we can do about it, right? And that's the questions that we ask. Like when we look at all the different systems, can we reverse that? Or do we have to put band-aids with a little Advil or give you some Adderall or give you an antidepressant, right? And that's how I practiced medicine for a long time because I really thought that they were all individual things in themselves. But really what we should be thinking of in terms of hormones is that it is a widespread system attack when we lose our hormones. And if someone is able to get hormones, because not everybody is able to get them, right? There are some disease processes where you cannot get it. Most people don't have those active disease processes. And if you don't, doing something about it is not only in our interest, but it helps us to just cope, cope in work, in the workspace, cope with life, cope with our kids, want to do more things and for longer. So yeah, these are all the things that can happen.
Okay. So what I'm hearing from you, Dr. Van Horne, is when you're looking at, gosh, saying it like this, treatment for menopause, it sounds like menopause is like a condition to be treated. But when our hormones are falling off,
right.
And we know that menopause is defined as we've gone 12 months without seeing a period, right? Then we know that we're in menopause, but the symptoms start way before then, can be 7 to 10 years before when you're now in this thing called perimenopause, right?
Right.
So what types of treatment do you normally recommend? Is it usually just hormone replacement? Is that sort of the go-to?
No, so after I take a look at like where your levels are, and it all depends on where your numbers are, right? And a lot of people, it doesn't really matter what their numbers are, they don't want hormones. So so let's talk about some of the things that you can do. What does preserve our hormones for longer is less stress, which is why I kind of think that our generation is having such a more profound impact because we do have more stress, I think, than our mothers. Not to say that they didn't work, they weren't outside of the home, but the kind of stressful environment that we're having, the kind of crime, the war in the world, just the craziness, even going to the airport and boarding a flight. When they boarded a flight, they did not go through what we are going through now. Everything is just stress, right? So That's what's actually, I think, leaching out our hormones more. So the very, very first thing that needs to happen once you realize that you're really getting burnt out, right? Because that's what I really see when you're going into menopause earlier, or for men, they're going to your andropause earlier, or I'm finding like young girls with like testosterone levels of like whatever, and they're not interested in sex. So that's a problem. Like if you're 20 something years old and you don't want to have sex, you're not interested in going out to parties, then your levels are a problem. So then it now shifts to, we have to do something about your lifestyle. Those things are get more rest, get out in nature. Studies show that, you know, being around trees, being out in nature, being at the beach, being in natural water, outside, how we were ancestrally before we got civilized, right? Those things help us to restore our hormones, which is probably why, you know, tribal people, although it looked like their lives were so hard, they were always being restored, right, by their environment. And they were always exercising because it took them exercise to get what they needed to get, right? So our lifestyles have to change, right? The other thing is that pets, you know, there's a lot to be said for pet therapy. You know, people bring pets into the hospital sometimes, or into nursing homes sometimes for patients, and there are studies that show that yes, that does decrease your cortisol, it does decrease your adrenaline levels, and adrenaline and cortisol suppress for sure your testosterone, but at the level of your adrenal glands, you make a little estrogen there too. And so you, once your adrenal glands are more relaxed, by not being in a stressful environment, you can then produce more hormones, right? So that's perimenopause. That does not work with menopause. Menopause, you lose your ovaries and the shop lock. But before that, those things can help. So adrenaline and cortisol are things that we want to kind of target before we get into menopause. Another thing that you can do is ashwagandha. Ashwagandha was used in India for many years. And it was used in people who had nervous breakdowns, right? And ashwagandha decreases your cortisol and it decreases your adrenaline. And a lot of people's cortisol, I mean, testosterone levels and estrogen levels may come up even just with that, right? What else is there to tell you about naturally? I mean, those are the big ones that I tend to look at naturally, and to make sure that your vitamins are optimized. Your vitamin B is optimized, your vitamin D is optimized, your vitamin B, all of your receptors need vitamin B as a cofactor to get things into the cells. So when those things are off, you can't metabolize your hormones properly, or your hormones can't get into cells to do the end organ responsibility that they have. So you want to look at all of those things. So those are the kinds of things that I discuss with patients who either are reluctant to at first, and so we kind of see how that goes for like a little 3 months, 4 months, 5 months, however long they want to wait. And then it just depends on how badly do you feel, right? So if you're at work and you are getting anxious and crying in your car because you don't want to go to work because you're that overwhelmed, then ashwagandha is not going to help you. And hanging out with your pets and buying more pets is not going to help you. And you could be in the sun and go to the beach every weekend, every day. That's not going to help you. So there are some people who just need replacement because they're at level 0, right? So looking at the numbers and looking at your complaints helps me to know what zone you're in.
Okay. Well, I love that, because we've talked about all the natural stuff, and I think, certainly speaking from personal experience, I've kind of reached the end of that natural stuff. So
right.
if we take it to the next level, what are some factors that, I mean, myself included, is that what should we consider now if we are deciding we're going to take that leap to HRT? we're
Right.
kind of on the ashwagandha, the nature, that all of stuff. Now, what do I need to consider? What are the
Right.
factors involved in really getting into HRT?
So the biggest thing that one has to consider, and I guess, for me as a doctor, when I started going to menopause, I really thought, well, I don't remember my mother talking about menopause, so I should be able to do this thing like fine. Like, why do I need anything? And I was gonna just rough it out, to be honest. To be honest, a lot of the symptoms I was having, I didn't connect it to perimenopause or menopause. I just thought I was working too hard. And the reason why I think there was a disconnect in my mind as a physician was because I have a problem with taking synthetic hormones. And I know the benefits, but I also know the risks, and I didn't want the risks. And so I think for most women who are kind of coming up on this decision, what's important for them to know is that there is a difference between bioidentical hormones and synthetic hormones. And the bad rap that hormones has had over the years really have come from synthetic hormones. So our birth control pills, they do wonders, but they do have adverse effects, and those adverse effects tend to get cumulative as you're on them for longer, right? I didn't want to go that route. I already had fibrocystic breasts. I didn't want to get more lumps, and not only that, but the birth control pills they decrease your testosterone, and I was already exhausted, and so I didn't want to go that route, right? And so if you don't want to have sex already, taking the birth control pill is just going to make that a done deal. You're not going to want to have sex for like months. You're gonna have to be like totally coerced to like be interested, right? It's one thing to take birth control pills when you probably had testosterone levels in the low hundreds when you were younger.
Mhm.
It didn't affect you then, but when you take birth control pills at this age, it that tends to be an issue. So I didn't want to take synthetic hormones. I had hot flashes, but I had already been somebody who was always very cold, and so the hot flashes, though they were bothering me, it didn't rise yet to the level of where I thought I wanted to have something. But had I gotten to that stage, I probably would have considered a patch, right? And you have patches that are bioidentical in nature. You also have creams that are bioidentical in nature. And that would probably be, as I was thinking about it in my journey through my head, that would probably have been where I would have stayed, right? Now, the estrogen is going to give you some replacement for that cognitive stuff that we go through, that kind of fogginess that we go through. It will help the hot flashes, certainly. It may help some of the joint pains and aches that you have. But there are some very real things that testosterone does, and testosterone actually your ovaries produce more testosterone than it does estrogen, which is another thing that women tend to not know. It's just that we don't have as much as men, right? But you need testosterone to decrease your anxiety. You need testosterone to sleep well at night. You need testosterone as an adjunct to estrogen to be a natural anti-inflammatory for your muscles and bones and joints. And if you're going to be exercising, you need the testosterone to build muscle, right? And it's that muscle building that helps your metabolism. So when you lose the testosterone, it's a huge deal, right? So in my initial part of the journey, as I was considering things and thinking I feel like so much crap, that part of it was I didn't consider. So I started doing more research, and then I realized bioidentical hormones was a thing. But the issue with patches and the issue with creams as bioidentical hormones is that not everybody absorbs them the same. And when you use the creams, you have to put them somewhere where it's not going to touch other people. So you can transfer it to your kids. So like you put them here, you go to hug your kids, you'll transfer it to your child. If you put it on your belly and then you have a pet and the pet like runs and jumps on you, you can transfer your hormones to your pet, and then your pet starts acting crazy, and or starts losing hair, or whatever, right? These things have happened, which is why I can say them. And not only that, but you have to like wipe down everywhere. Like I have to use the cream. You can't touch the door. You have to wipe that down so it doesn't get on the kids, because they'll absorb the hormones, and you don't want your husband getting too much estrogen, so you have to wipe that, wipe down the counter and all this crap. So that's a lot of thinking. That's a lot of stuff, right? And there's some women who do it, and then and that's fine if they feel better with it. So a friend of mine, she and I had the same problems, and she did this thing called pellets. And she said, Simone, I really think that you need to consider this, not only just for yourself, but consider it for your patients. And I was just thinking, why don't I know about this thing? Why is a patient telling me about this? Why is a friend telling me about this? Like, I should know as a doctor about this. So I still had my concerns. So I asked the representative of the company to come to my office because I wanted to know more. I wanted to know the evidence. I didn't know about this, right? And what are these levels that you're checking? Like what is this? So he came and he invited me to be around other doctors who had really been in more natural medicine for many years. And the bioidentical hormone therapy really comes from soy and yam. And so these were really more functional medicine doctors, and they were more, they were not as enthralled with pharmaceutical medicines the way I was practicing. Let me just be frankly honest. So it was like a new thing, but like, my journey in medicine, which I kind of told you about, like I did everything from HIV to, I even do aesthetic medicine. Like I just have an interest in learning. So I was very interested for myself, but interested as to why I don't know about this after so many years in medicine. Why would I not know? So there's a lot of in research that has been going on over the years, but in the 1960s, 70s, 80s, which is when our mother's generation would have gotten turned off of hormones, is when this study called the Women's Health Initiative study came out. And the Women's Health Initiative study had to be pulled. It had to be pulled because women were getting strokes and they were getting heart attacks, and there was even cancer. And so based on that, our mother's generation are very averse, because that would have been in the news and in the newspapers and whatever, I imagine. And for me as a physician coming up, those were the things that I learned, right? And so but me practicing in the United States, being a very liability conscious place, it was like, I don't even want to hear about hormones. I let them go into their OB-GYN. I don't even need to know about it. So I literally kind of cut off that whole conversation, I think. And until I started going through it now, I was like, okay, what is the evidence now for, let me find out what can I use and what can't I use. And so they've been doing this in Australia, they've been doing this in Europe for many years, and there's now a resurgence now of physicians who really have kind of opted to not have pharmaceutical companies dictate what's good and what's not good. So what has happened in medicine is that because the pharmaceutical medicines do have a problem when we've used them for a long time, and because unfortunately a lot of our research and the research money and the money for lots of the activities that we do in medicine are paid for by pharmaceutical companies, what then happens is that when you have more natural things that you can't brand, because you can't brand a molecule that comes from soy and yam, it is the identical molecule to ours, that kind of got left in the wayside, right? But now there's a lot of research, a lot more research, and this is where we are, where bioidentical hormones as the natural hormone, an identical hormone to what we have in our body, does not cause the things that synthetic hormones do, right? And that is the research that women need to get engaged in. The Women's Health Initiative study is really what caused the big rift in medicine, where we decided we were not going to use hormones unless somebody was on like death's door, unless somebody was like having, you know, they had to be in the bath all day for their hot flashes. They would be like, okay, we'll give you a birth control pill. Okay, we'll give you a patch. Okay, we'll give you this, right? But for a short period of time. But we can use bioidentical hormones for a longer period of time. In fact, my practice began, and I still have a practice in a senior living community. My oldest patient is 98 years old. She'll be 99 next month. And I use testosterone for her for pain, right? Because the inflammation is, although she doesn't have hot flashes anymore, and she's not that moody or anything anymore, the pain limitations and the exhaustion, the fatigue, just sitting down and falling asleep, a lot of that in elderly patients is also the hormones. So my practice and my growth as a physician has completely changed, really, since I've gone into menopause and have done the research. And
That's,
you know,
that's amazing, and we really appreciate, because there's so many physicians that don't dive deep. So a lot of women are sort of floundering in this lack of knowledge and awareness. And as you rightly said, our parents' generation didn't really talk about this stuff. So I remember looking back, I remember what I now can recognize as my mother going through menopause.
Right.
But I didn't know what it was at the time, you know?
Right.
So,
Right.
now it really sounds like what you've said is that, you know, we were scared away by this study that might have been flawed in its cohort and whatnot. So we're really seeing a resurgence of information and studies that say, hey, it's okay to do this, and we don't have to be dying from symptoms before we look at it. But you mentioned that there still are some contraindications. So who is it that should be avoiding hormone replacement therapy, or for whom would hormone replacement therapy not be a choice for you?
Well, if you actively have breast cancer, you should not be doing that. And there are some women who have very, very, very strong family histories of breast cancer. That should be a very deep dive into what kind of breast cancer, what kind of receptors, because some of them have estrogen receptors, progesterone receptors. Some of them don't have any receptors at all. Like, that should be a very in-depth conversation. Not to say that testosterone cannot be used, because testosterone actually decreases the proliferation of breast tissue, and progesterone also decreases the proliferation of breast tissue. But that has to be a very different kind of discussion. And to be honest, women who have breast cancer or have gone through it, they are very reluctant to even consider anything like that. There is a physician, her name is Dr. Rebecca Glazer, and what's the name of her website? I think it's millennialhormone.org or something. You know, I'll send it to you guys after. I can't remember. It's in the presentation they had. But a lot of the knowledge that we have right now, when it comes to testosterone specifically and breast cancer, really comes from her. So she was a breast cancer surgeon who had a whole bunch of patients who did not want chemotherapy and who did not want what their doctors were offering them. And so she, realizing that testosterone actually decreases proliferation of breast tissue, opted to treat those women just with testosterone. And women were living more than 5 years with testosterone pellets that she just put around the breast cancer. And So that was an arrangement between her and them, but it then progressed into looking more at testosterone replacement, and really what does set us up for with breast cancer is that, because with the dip on, our breast can then proliferate more and then proliferate, and that Dr. Rebecca Glazer, all of you who are really interested in and afraid of breast cancer, like that would be something to look at. And so I do have not many patients. I have the odd patient who, when you go through chemotherapy, what they do is kind of basically castrate you of any estrogen whatsoever. Mm-hmm. And there's some women who say, I'd rather die than have that. And they decide, I'm not with it, right? And for those women, I will use testosterone if they're more than 5 years, like past that, right? And the studies are showing for those women that that is actually more humane, right? Because to have that kind of exhaustion and pain and all of that, right? And a lot of that came from Dr. Rebecca Glazer. I would implore you guys to look at her website, because she has all that research, all the things about the myths, all the things about the patients that she's been treating, and it's exceedingly scientific, and it has most of the research that we now know about testosterone therapy and its benefits.
Thank you very much for that.
That's where it comes to women. And then for men now, of course, if you have active prostate cancer, then you're not going to be able to have it either. But that really is about it, because really we're not giving you something synthetic, and we're not giving you a molecule that your body is not already used to. It's kind of like if a diabetic doesn't have insulin, we're giving you the molecular corollary to that, right? And so what happens with the synthetic hormones is that, yes, you have the appearance of the molecule, but you also have like all of these extra molecules that are on it. So if you think of a hormone and cell as a lock and key, mm-hmm. Your synthetic hormones will get the key in the lock, right? But as you turn that lock, it's not going to be nice and smooth as it is with a bioidentical hormone or your natural hormone. And then when you're turned the lock, you have to kind of jimmy it to kind of get it to turn, and it will turn, and you can get in the door. But all that jimmying is like your adverse effects, your clot, your stroke, your cholesterol going haphazard, like all of those things. And those are the things that we see with synthetic, right? And even the cancer, right? There probably will come the point where we fully work out what the relationship is with our estrogen and our progesterone and testosterone as it relates to cancer. And as it relates to bioidentical hormones, I think a lot of the research is not being done because of the liability. But I think there's going to be a lot to learn in the future. And so that fear that women have, as long as you don't have like all of these tons of risk factors, right? And that makes up 80% of women, I think that you can relax through the process of choosing for sure a bioidentical hormone to use. Women who do have more risks, I think that needs to be a very one-on-one conversation. Not to say you cannot do it, but that exactly what we're dealing with has to be explored.
Okay, well that's a lot of great information. The fair on HRT, a lot of women, if we're talking about the whole cancer fair of HRT, how do we?
I didn't get the question because I think you're I don't know if you're lightning flashing again or.
Oh, it's also the weather here, and I hate to keep my camera off. I apologize, but I'll keep it off because I keep popping it on. Okay, I was talking about the fair. We talked about the fair of HRT and the women and all of that. But Okay, so we need to push through. When do we need to start having these conversations with our doctors or internists or whoever we choose to? When should we be?
Well, you really should start to have this conversation. I would say like in your early 40s, right? Because that's really where the symptoms are beginning, right? A lot of the antidepressants and the Xanax and stuff that we're giving people really are their hormones. But when you say that when should be having that conversation with our doctors, the other part of it, which is the part of it that I eventually want to get to, is where I and the company that I actually deal with, we want to, as physicians, go into where doctors train to change this, because the fear is actually happening at the level of your doctor, right? Because of these past habits that we've had and these past studies. And so we're trying to like shine light on the newer studies that are there. But it takes a while for habit to change, right? So I say all that to say that you really need to have a doctor who knows about these studies, and you need to have a doctor who knows about hormone therapy specifically, right? Because that conversation, like I was telling you about the blood work that I check estrogen levels, I check your FSH levels, I check your testosterone levels. And a lot of doctors are not going to check your testosterone levels because they don't really know. And to be honest, I'm not trying to say that your doctor doesn't know because they're stupid. I didn't know 2 years ago, 3 years ago. I didn't know until I went into menopause myself and did the research. So it's going to take a while for that to change. Unfortunately, we're just kind of in the change happening. And so that's what I would say. If your doctor doesn't know, I don't think that it means that your doctor is not a good doctor. We're still in the change, right? And as doctors, you have to understand, we're seeing like 20, 30 people a day answering calls, sending medications. We have to go home and then find time to read, but we do have like a family, and we do have like, we do want to go out. We do want to like, so it is until somebody goes like, no, you need to look at this, right? Like put it up in our face. The way, my friend and my patient did with me. And until doctors keep kind of hearing it, I mean, a lot of them would probably like reject what being said because we know that, and that's what we were taught, our professors taught us that. But it's a while to change. And so that would be my only advice, that you find a doctor who understands that. And once you start having that conversation with your doctor and you find that they just want to give you an antidepressant or they want to give you Adderall because you're falling asleep at work, that's a stimulant is not going to help long term, right? What's long term, you need your hormones to be balanced back.
Thank you for humanizing doctors to us, that you want to go out and you have a family, because I find that so many people still, I have a lot of respect for doctors, don't get me wrong, but we tend to think of our doctor as the authority on everything to do with the body. And I love that you you humanized your profession. So thank you for that. And it's important that
You're
we
welcome.
educate ourselves, right?
It is. I mean, and to be honest, when I went with my other colleagues who were sharing like all that information and stuff, I went through a good amount of anger because I was like, but I've been treating people like crap. Like, I mean, I even myself, I didn't have to go through half the stuff that I was going through. And I was like, why were we not taught this? Right. But this just really kind of, what I'm trying to kind of show you is that we're having a kind of silent war between natural therapy and pharmaceutical medicines. And it's going to take a while for us to, it took a while. I mean, before we used to like maybe even ginger and, whatever natural things, especially us, in the Caribbean. Well, we kind of went away from that, and we kind of believe in taking, if it doesn't have a medicine, if it doesn't come from a box, it doesn't have like a bunch of side effects, then that means that it's not, somehow that got warped. Like that is better than something natural. And it's just going to take a little while for that pendulum to swing back. And people as the consumers, patients as the consumers, are going to put that demand on doctors to read more and to see what they're saying. And also it's going to take at our level for those of us who have changed or who are seeing. I mean, for me, the big things are, I'm taking you off antidepressants, I'm taking off your cholesterol medicines, I'm taking you off Adderall, because I thought that the reason why you had ADHD, that's why you couldn't focus, right? Or you're forgetting everything. But once I balance your hormones, you're like, I don't need it anymore. And so for me as a doctor, that's huge. That's huge. Take you off of medicines where people come to me, you give me another medicine again. Right. Well, now I can take you off a lot of medicines because I can get to the root of what's happening.
So what I'm hearing from you as well then, Dr. Van Horne, is you're not just prescribing the hormone replacement, but you're monitoring the changing levels or the improving levels, and you're also monitoring how it's impacting the other conditions to see what you can balance out. That's amazing. So, yeah.
And that's kind of different for me as a internist as opposed to a OB-GYN. Not to say that OB-GYN is not going to be looking at that, but that is another part of my focus. Like stroke and heart attack, they're not dealing with that. I'm dealing with the fallout from stroke, heart attack, diabetes, everything. And so I'm looking at, when your hemoglobin A1C is creeping up because your testosterone levels are coming down, and there's a relationship there as well. I can show my patients like how that is happening, and how we're getting away from that, right? So there are a whole bunch of things that happen on an internal medicine level, yes, that I can avert, right? So it's not just about hot flashes and vaginal dryness and they don't want to have sex. Yes, your OB-GYN can navigate that, but the other parts that I have to follow are your osteoporosis risk, right? I mean, balancing your hormones, after 3 years, you go back to the bone density of what you had when you were in your 20s and 30s, right? So there are huge benefits that don't have to do with just hot flashes and feeling good. You feel better, but underneath all of that are some real internal medicine caveats that are important for you living longer, and that deserves.
How soon after you start a patient on hormone replacement do you start to see improvements in the condition? So I understand the heart and the bone density conditions may take a little longer, but how long do you start to see in the feel good or any of them? How long does it take before you start to feel a difference or see a difference?
So how I do hormone replacement is I do it by pellets, which let me explain that to you a little bit. I take your blood work and I see where your levels are, and based on your age, your weight, and that level, and how you're feeling, the symptoms that you're complaining of, and your past history, I then tailor a dose for you. So you would have a different dose from me, you would have a different dose from every single woman who's on here, because I am replacing you to where you were in your 20s and 30s, and it's not a generic amount. The pellets come like little rice grains, right? That's basically what they look like. And then the estrogen ones, they tend to be like a quarter of a rice grain, because that is really the relationship of testosterone to estrogen we have in our body. And it requires a procedure where I inject you with lidocaine. I put it wherever you have more fat. We're kind of at that age where we tend to have a little bit more fat everywhere. But, is where, women tend to have a little bit of love handles, but some of them are extra fit. I can't find anything there, so I go to the bottom. Or my elderly patients, sometimes they don't have anything there and they're more petite, and I give them in the buttocks. But you don't feel anything except the lidocaine injection, basically. And then after that, I insert that pellet under there. And for 5 days, you 4 or 5 days, I ask that you don't do any vigorous exercise. Like you can walk, you can run even, but I don't want you doing any deadlifts or whatever, you know, no big muscle bulging to happen to push out my pellet. And then patient say in about 2 weeks, their sleep gets better. But for sure, I don't ask any questions until a month later, in which really all parameters may not be completely resolved, but most people who come to me, they're like in severe physical exhaustion, severe irritability, severe anxiety, severe muscle joint aches and pain, severe hot flashes, can't sleep at night. You know, everything is severe. Vaginal dryness, severe. Sexual, severe. And when they come back to me in a month, those things tend to be more moderate. Okay. And then when I talk to them, like in 2 months after that, they are now either mild or none. And that's a successful patient for me. So in a month, everything is going to be much better. In 6 weeks, for sure, no more hot flashes, and the hot flashes never come back, right? As long as we keep the levels the way they should be. And I'm consistently checking your levels, right? Month after, I'm checking to see where you are. And then sometimes I do check right before the pellet just to make sure that you are where you should be, right? The pellets last for 4 to 6 months. Some people are very, very active and they burn it out. And so those people tend to be 4-month people. And then you have some people who are not very active. You know, my patients who are in the nursing facility, they're not doing too much. They last like 6 months, right? So, or you have a more relaxed lifestyle, right? Maybe you work from home. You know, maybe your job is stressful, but you work from home. You're not up and down, going up and downstairs in traffic. Yours might last for 6 months. So I don't know that until I check you to see where you are. So everybody's different, and that's kind of what I liked about this way of administering it. The other thing is, when I put the pellet inside, blood vessels grow around the pellet. And then depending on what your cardiac output is how you absorb the hormone. So if we're talking like this, you don't need too much hormones, your heart rate is not that high. But if you start to exercise or somebody gets you upset or there's a death in the family and you can't, you know, you go to bed and you can't sleep, what then happens is that you absorb more and then you start to calm down more. So it mimics your physiology, and you can't get that from an injection. You can't get that from a cream. You can't get that from whatever else is out there. You know, this is what women, I personally think, should be taking.
So your body naturally draws as it needs more. It draws. Right. That's phenomenal. Are there any side effects to this method of
so delivery? the main downside is what you would have been like when you're a teenager. So as a teenager, I struggled with acne. So I have to fight up with acne again, but I'd rather fight up with acne, to be honest, and treat myself for acne than treat myself for
all those other things.
I can't remember my patient's thing. My patients get pissed off because I forgot whatever, you know, don't remember somebody's birthday and they think I hate them, and you know, I think I'm all of that, and I didn't remember. No, I didn't remember because I'm in menopause. So you're right. So yeah, so if you had acne when you were in your 20s, I'm gonna have to start treating you in advance for that. And I give something to the testosterone receptors in the face, and you can get your hormones, right? Then some women, if they've been deficient for a long time, what can happen is that they can get a little swollen, a little fluid retention initially, but then that goes. And then if a woman who haven't had a period for a very, 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 very long time, and the uterus sees that hormone back, sometimes you can get a little spotting. Sometimes you even can have a one-time period. If you had polyps and things like that, they can then reveal themselves with more spotting. And then that's when I might have to send you to a gynecologist to investigate it and get those removed, etc. Is there anything else? Yeah, breast tenderness, you know, stuff that you had during your period. So we have to kind of work out your dose, right? So to make those things not happen. But the biggest thing that freaks women out is the spotting, especially when they haven't had a period for a long time. They're like, what's that? And we have to work out the dose, or sometimes they do have something that is revealing itself, right? Like a fibroid or a polyp or whatever.
Right.
And then we have to deal with that.
Okay. For a woman who has already started hormone replacement therapy and is on an estrogen cream and a progesterone pill and that sort of thing, and they want to switch over to this delivery method, how would you manage that?
We just have to know what the delivery method is, and I put that into the calculation, and then what happens is that you stop like after a couple of days from whatever it is, depending on what it is, it requires different days, and then the other one will take over.
Okay. Okay.
Yeah,
Well,
that's not an issue at all.
we're coming up to 1 o'clock. Unfortunately, Nikki is in the fabulous Portland, and fabulous Portland is having all sorts of crazy weather. My lights just dipped a while ago, and I was like, oh no, we both can't leave power. But I wanted to just ask if anyone on the call had any questions. If you could just drop that in the chat for Dr. Van Horne. And Dr. Van Horne, you are in the US of A, we are in the JA. How do people, if people have really connected with you and want to connect one-on-one, how do they do that? Okay,
so my website, www.vipobservation.com.
Yeah, we dropped that.
If you go on the website, it has the phone number, but it also has a little contact form where you can put your name, etc., and then we will contact you. Or there's a book now link, and you can just book now right there. And we do telemedicine consultations from wherever you are, right? And for people who are like in other states, sometimes they're passing through Florida twice a year, because this is really only needed twice a year, right? So they could see me twice a year, or we can figure out who close to you does what I do, right? That's also totally feasible. For the people who are in Jamaica, as I said, I'm trying to make it so that I am down there every month for sure. So probably by the last week of I'll let you know, and then you can let all your different people know. If that response is very good, I can prepare to come like every other week if needs be.
Okay. And what do people expect in that first session with you? What could people expect?
So in the first session, what I do like so when they do book online and stuff, what happens is I send them links to fill out paperwork online about their past medical history, so I can have all of that. I send them a health assessment questionnaire that has all of those things. Are you physically exhausted? Is it mild? Is it moderate? Is it severe? Vaginal dryness, bladder problems, can't hold the urine, all of those things. Right. So you itemize all of that. And then what I am planning is that when I come to Jamaica, I get the blood work, and then 2 days after that, I'll have your results, and we can have a proper discussion. I think that discussion is much more fruitful rather than you paying like 2 sets of money. I think I prefer for me to have that consultation session when we have the blood work, so I can connect your past medical history with everything on.
Gotcha.
So any woman who's like learned that she's in perimenopause or menopause, that's likely what's happened. What you can then do is just book through the office a time when we're in Jamaica, so that we can take your blood, and then we book at that time your telehealth session. Got it. That's amazing. Yep.
Well, I'm not seeing any questions in the chat, but I do have Anne who's very interested. So
okay.
Dr. Van Horne, you have provided us with a wealth of information. I hadn't even considered the pellets and the testosterone and everything that you've been talking about. So I really thank you for your time.
You're very welcome.
We're glad to continue the conversation. Nikki is apologizing profusely because of
It's okay, Nikki. It's okay.
This has been a disaster for me. I apologize. Total disaster. But I've been listening on and off. But thank you so much. I'll have to watch the recording.
You get to watch the recording. Yeah, and anytime you want to have me back, right? There's a whole bunch of stuff about testosterone. There are a whole bunch of other stuff, right? Like, so whenever you want to have me back, I'll be more than ready, willing, and able to educate, right? Because we really need to know. That's part of what I don't like about what's happening is that we don't know, and we should.
Right, right. Thank you so very much.
You're welcome.
We'll share this recording to the participants who were not able to join. So again, thanks for your time. Have a great day.
You're very welcome.
Thank
Bye,
you.
guys.
Thank you.
Take
Bye.
care.